because of antimicrobial resistance. The other thing, of course, that we know, so I'm going to share some non-human primate data with you, but let me tell you how I got here. Whoops. The other problem, of course, is that just making more antibiotics is not working anymore. We've run out of them. And we had hoped that adaptive immune responses based upon vaccines would be the answer. But it turns out that the vaccines we make only work for the antigen with which you start to make the vaccine. So, for example, if you take Shigella or Salmonella, you get a great vaccine against the strain that you make it against, but it's useless against all the others. And for a long time, I've wondered whether we shouldn't actually be trying to just manipulate cytokines of the innate immune response. And the advantage of this would be it would provide you with short-term protection, because we know when you get a severe infection, you get a big cytokine response. It's independent of antigen. It shouldn't upset commensal bacteria in your gut, and you wouldn't get any kind of resistance. And the reason this is important is that in the last 10 years, these sorts of heroic charts have appeared, which show all these toll-like receptors on the cell surface. And although the biology is very complicated, not all toll-like receptors are the same. Some are more important than others. And certainly for severe infection, toll-like receptor 4, which binds lipopolysaccharide, is the one that will kill you. So if you're going to die from an infection, this is the receptor that will kill you. And to look at it another way around, LPS binds here at the toll-like receptor and triggers a cascade of cytokines, which include things like TLF and IL-6. And there is a bad part to this cascade, which is these cytokines here, which are designed really to kill bacteria, but actually they cause a lot of injury to the host. But there's a component to this pathway based upon TRIM and TRAF, which produces interferons, which then causes adaptive responses, particularly in dendritic cells, and is associated with a degree of an inflammatory response. But actually, this side is very good for you. So the reason I'm still alive and grey is that most of the time I've been triggering this pathway when I get ill, and not that pathway. And so what we argued is that if we could make an antagonist up here that would block the left-hand side, but keep the right-hand side intact, we may actually be able to treat a very severe infection without ever using an antibiotic. What we wanted was septic shock, really, which was limited to just one tissue compartment, because trying to do systemic shock across the whole body is just too big an ask in the first instance. And this is Shigella infection. So what you have here, Shigella infection gives you bloody diarrhea. Really nasty, vicious, bloody diarrhea. So what you have here is you have the colon of a human being, which is normal, and these are all your lymph nodes. And what Shigella does when it invades is that it punches holes through these lymph nodes. And in fact, this is a patient who has died. The colon has been opened, and the surgeon is pushing his finger up through the hole here because the response, the septic shock, has been so severe that it's punctured a hole through the wall, and of course the patient then gets the spread of bacteria throughout the body. So we worked with this model on the basis that this is as bad and as severe an infection of the gut as you can get. And as I've got older, I've realized that actually the reason why I don't get ill, despite having bacteria in my gut, is that the gut wall is intact. And as long as my gut wall is intact, I can have a very healthy relationship with the bacteria in my gut. But in fact, what bacteria do is that bacteria need to create a boost of cytokine first to break down this epithelial barrier before they can invade. So we've actually got this wrong. We've always believed that first you get the bacterial infection and then you get the inflammation. Actually, I said we've got it wrong in that that's my gut wall. The bacteria rather cleverly trick me into making cytokines that make my gut wall like this. And once my gut wall is like this, it's Christmas, and you can cross over to the other side and cause infection. So in fact, infection comes second, and inflammation comes first. It took me about 25 years to work that out, but I think that that's what's going on. So what I argued is that if that's really true, if I could just reduce inflammation, I could prevent neutrophils coming into tissues, and I won't need an antibiotic. So in other words, in a severe infection like Shigella, you create so many, these are the bacteria in the gut lumen. You create so many of these cytokines like IL-6 and IL-8 that they actually act backwards and damage the gut wall. You lose the barrier, and bacteria then come through and then make you very ill. The reason the concept was important is that, in fact, this is toll-like receptor 4 here, which is a dimer, is that the lipopolysaccharide, the lipid A component of lipopolysaccharide from all these bacteria, Shigella, Salmonella, E. coli, Klebsiella, Enterobacter cerevisiae, they're all identical. So if you could prove this for Shigella by making an antagonist to this compartment here, which sits within there, the concept should apply to all these gram-negative bacteria and therefore would have a huge impact on antimicrobial resistance, which is a world crisis today. And we did a whole bunch of modeling work, and we showed that for lipid A, which is a critical part of lipopolysaccharide, it binds to lysine 91, tyrosine 102, and serine 118. And the dendrimer that we made, which is a 16-mer, a carboxylic acid-terminated dendrimer with glucosamines on it, actually bound to arginine 96, tyrosine 102, and serine 118. And 102 and 118 are the critical amino acids that you have to block. So here in purple, the dendrimer is sitting over this pocket and preventing that whole cascade from starting. We then went and made the dendrimer, glucosamine, with glycosin in New Zealand. And glycosin in New Zealand are actually the company that did all the drug development work for Star Pharma in the days that Star Pharma used to work with them. And I'm not a chemist, but we managed to get really very good purities and make up to about 20 grams of this, 30 grams of this stuff, really by repeated iterations to get to a generation 3. And then, of course, the headache is always in the analytical chemistry. If I'd known how hard analytical chemistry of dendrimers was, I'm not sure I would ever have gone there. But having started, I had to finish. And we managed to get a MALDI here of the core dendrimer at 2,666, and HPLC showed a 97% purity. And then we went on, and we in the end had to use 800 megahertz NMR to get these sorts of mass spec pictures to show us that where the anomeric protons were for the glucosamines. And then we also went on, once we glycosylate the molecule, to show that we had 97% purity. And the difficulty here was that we had what we thought was a rather broad peak. But when we collected 16 fractions from in here and did NMR on them, the NMRs were all identical. So we thought we had really what was a very good molecule at that time. And so we then went to Philippe Sansonetti, who is the world authority on Shigella infections at the Pasteur in Paris. And Philippe has a rabbit model of Shigella. And he tested the molecule for us by giving it orally. And when you get Shigella infection of the gut, it completely destroys your gut wall. You know, this is just chaos. You've got, it can't be any worse. And what happened is that when we had given the DG molecule at the time of infection, you can see that the gut wall here is beautifully preserved. I can follow it all the way around, and mucus is present, and we gave no antibiotics at all. So we went to NIH and to the US Army, because believe it or not, diarrhea is a huge problem for the soldiers in Afghanistan and in the Middle East. And the US Army said that actually 20% of our soldiers go down with severe diarrheal diseases. And so they have a facility of 600 monkeys paid for by Congress, US Congress in Thailand, completely dedicated to diarrheal diseases. So NIH paid for a $1 million study, randomized, controlled, placebo-controlled in monkeys, to see what would happen if you caused Shigella infection in monkeys. This is just a slide to show you in the lymph node the injury with infection and the protection with the DG. So they paid for this study, which was done as a GLP study to FDA regulatory standards. And I have to say, the only people who can do this kind of work are the Americans, because they have such deep pockets. We started with 40 monkeys that were isolated on day -35. And then using a computer program, we randomized 18 of those monkeys on day -14, having made sure they'd never been exposed to Shigella, and they had no evidence of Shigella infection. And then of 18, we randomized 14 on day 0 to infection. And what we did is we infected the animals and we gave them the DG, and we were allowed by the international regulatory authorities to treat the animals for 6 days, because really by day 6 you have 80% mortality in the infected group. And importantly, we were also given permission to kill the animals and perform an autopsy, because that permission is not normally given. And it was agreed that the animals would not be allowed to suffer, but they would be given fluid rehydration by a vet, but they would not be given antibiotics. So here was an opportunity to really check and see whether if you stop inflammation, you can actually treat an infection without giving an antibiotic. So the study group ended up, and we had to do this in a containment level 3. The organism we use, the Shigella, is as dangerous as HIV infection. So if you catch 10 of these bacteria, it will kill you as a human being. So we had to do all of this in a level 3 containment facility, which is the same level in which you have to do HIV work. And we had 2 normal animals where everything was done as placebo. We had 6 animals that were given the Shigella dysentery, which produces the Shiga toxin, which is what kills you. And we had 3 animals that were given low dose, which will be referred to as a total dose of 214 milligrams. And 3 animals that were given a higher dose in the study. So just for I'm going to start with the clinical data. So what we have is a clinical score, which is generated by the vet. The first column will be the normal animals. The second one is the Shigella animals. The third column here is the low dose, and the fourth column is the high dose. And the take-home message in the study is that the low dose showed no significant response, but the high dose showed a highly significant response. What we have here is we have in these animals, in the Shigella animals, you get a lot of blood and mucus and diarrhea. And you can see that we have reduced that from something like 85% down to about 30% in the high-dose animals. If you then look at inflammation as a score, using established parameters for inflammatory bowel disease, you can see that these animals have a natural degree of inflammation of about 50%, which then goes up to 100%. But if you look at the high dose here and look at the right-hand side, you can and you call the infected animals 100%, you can see that you've actually reduced that by 70% as a blinded score measured by a pathologist at post-mortem on day 6. And if you ask why has this inflammation gone down, the main reason the inflammation has gone down is that this yellow bar, which is neutrophils, have fallen by 75%. So what's happened by preventing or reducing inflammation is you've prevented neutrophils coming into the gut wall and destroying the gut wall. And what was a very interesting and unexpected result is that we found that vasculitis, which is a very major part of this illness, was completely abolished in the high-dose animals, and fibrin, thrombin development was also abolished. So we were very, very surprised. If you can reduce this degree of inflammation, you can actually abolish the injury to the blood vessels too. And that no one had ever realized that that might be possible. We'd never seen that in the rabbit work. So in the end, actually, you just need to look at the pathology of the pictures from the gut. So this is the colon of a normal, healthy animal, and here is some stool stuck to that, and it's got lots and lots of undulations. That's what a nice, healthy colon should look like. This is from an animal that died of Shigella infection. There's lots of hemorrhage, and the tissue is much more flat than it is there. This is an animal that was given the DG. Remember, no antibiotics have been used, and just some fluid rehydration, because the animals become anorexic, so they don't eat and drink, so you have to give them some fluids to stop them dying of dehydration. And you can see there's quite a lot of stool here. You've got lots of these folds. And here's another picture of another animal showing 15 centimeters of the colon, and there's some form stool. There's a little bit of injury. There's the odd spot there and the odd spot there, but really it's tiny compared to the amount of injury you see in this animal here. If you look at the histology, that's a normal histology of a colon. Nice and clear-cut line to follow. In the animals with the infection, it's almost unrecognizable because there is so much tissue injury, and you've got abscesses forming, and you've got vasculitis here in the blood vessels. In the animals that got the DG, there's some neutrophil infiltration, but really it's not so very different from that, and importantly, the gut wall remains intact. So why did this happen? Well, if you look at the cytokine responses, this is a slightly complicated slide showing normal Shigella, low dose and high dose, and this is IL-8, IL-6 and IL-1 beta, and I'm going to now just remove the low dose data just to make it easier for you to see. You can see that what's actually happened in IL-8 is that there's been a huge increase in IL-8, and we've brought it down by about 70% in the animals that got DG. There's a huge increase in IL-6, and we've brought it down by about 70%. And if you look at IL-1 beta, huge increase, and we brought it down, and it's statistically significant. And we have a lot of additional immunological data that is consistent with this, but I'm not going to show that today. So the concept is fundamentally right. If you allow bacteria to produce cytokines, they will destroy the gut wall, and bacteria will invade. But actually, if you can control inflammation to a reasonable degree, not only will you preserve your gut wall, but you'll make your endogenous antimicrobial peptides, because your gut wall makes its own antibiotics. And those antimicrobial peptides which you make here in the gut wall will do a very good job of bringing the infection under control. There have been a lot of people involved in this work over the last 15 years, at Imperial, at the Armed Forces Research Institute in Bangkok, at the Pasteur in Oxford, and in London, and in New Zealand, and in Texas, who should also be acknowledged. And of course, NIH and NIAID and ERC and EMBO, who have funded this work over many years. Thank you. Money. Money and a commercial partner. I mean, it's clear that you've reached the point where the next phase is to go into humans, but what NIH and the Army say is they say we provide money, but we don't make medicines. And you need to find a commercial partner. And we can even guarantee we will buy things. But actually, because we don't make them, we need industry to come on board and make things, so that we can then buy them. And that's the challenge in a new field.
So you heard two real important messages here. Oh, yes.
Yes, look, we know each other, right? So there are ideas or suggestions that inflammatory responses primarily also responsible for certain type of cancers. Could you please comment on that?
So
there was some similarity that inflammation comes later when this and that happens, but it all goes back to.
So you're absolutely right. If you look in a number of cancers, you can find that IL-6 is very important in a lot of cancers. I'm not a cancer doctor, but you're absolutely right. The challenge, I think, the beauty of infection is that I can decide that I'm going to infect my animal now, today, at 2:30, and I have a start point. The difficulty in cancer is that you don't have a start time. So when you diagnose a patient, you're already a long way down the road. And I think the trials of inflammation in cancer have been very difficult and very challenging. So it may be that we can learn from infection because we have it's the same thing in autoimmunity. It's hard to have a start. We can learn a lot in infection, which we could then transpose to cancer. But I think you're right. The future is immunotherapies. And in fact, many monoclonal antibodies are chasing those targets now.
To stay close to schedule, I just want to say one thing. The message was he successfully scaled up from CGMP to clinical quality material. That was part of the recipe. And the other part was you obviously had a well-designed prototype that was doing the job.
Yes, indeed.
All he needs is the money. I'm trying to work
But you don't even need academic money or grant money. You need to reach the point where you must have somebody who will make it commercially for a profit, because actually NIH says that's very important. for the future. Yes.
Private sector.
Yes.
Pharma companies. And the interesting dilemma is the market.
The market.
It's kind of almost an orphan drug type of market.
So we need a success. As soon as I think we have one success, the doors will open like floodgates. But everyone says, are you sure it will work in humans? Well, somebody's got to be first. I don't mind being second, third, or fourth, but somebody's got to be first.
I truly think you're very close.
Thank you.
Let's thank Sunil.